That was jam-packed with really good information for everybody. For the sake of time, let's jump right into questions. We have about 10 minutes. If any of our experts have a hard stop at 5:30, feel free to jump off if we go a few minutes over. But let me just pick a few here. I have a good one. Juliet's asking, what is the risk factor of IDH2? It seems to never be mentioned per the slides that were shown as either favorable, intermediate, or adverse risk. Why is that?
So I think that the IDH, first of all, IDH mutations are relatively less common compared to, let's say, NPM1 or FLT3, where we anticipate, somewhere about 10%, depending on whatever series you look at. It's harder to have specific sort of prediction data on a relatively rarer mutation. It also tends to be co-mutated with other mutations, and it's not like nobody. So that part of the thing is that there's no one that truly just has one mutation. I mean, you really get a mixture of this chromosomes plus these 2 or 3 mutations. Although there are data that have looked at, adding in NPM1. If you have IDH, does it make it worse or better? Some of them are conflicting. They're not standard. They're not in the standard ELN criteria yet for risk prognostication. Some IDH mutations can be part of clonal hematopoiesis, so you're they're there before the leukemia even happens and might be persistent even beyond. And some of the prediction is going to change because IDH mutations were considered sort of not good in the old days, but these days with novel targeted therapies, you're talking about HMA, venetoclax, they tend to do very well with IDH mutations. So these things keep changing. So you can't say something is bad before and it's still bad because novel therapies change any of this. So we're not actively looking at IDH mutations and making big transplant decisions just because of the IDH mutation. It is really a comprehensive take at how they responded, what are the other co-mutations, what chromosomes there are.
Yeah, that's great. And I'm not sure, Dr. Caraway, if people can read the chat, but she does mention that IDH mutated leukemias tend to be sensitive to venetoclax and Vidaza.
Yeah, I think that Dr. Desai just mentioned that, and so it's interesting. Every institution's a little bit different. Sometimes we have that information at the time that we make a decision for what patients are going to get. Sometimes we don't have that next generation sequencing data back, and patients embark on therapy, and then we learn about these mutations after the fact and use those mutations to help us say, does this patient need to go to transplant or not? Dr. Desai highlighted nicely that it's not always just one mutation. It's often that mutation in the context of other mutations, in the context of how many mutations en masse are there, and also what cytogenetic abnormalities are also occurring with that. And so if we have that information up front, many of us like to use then AZA-based therapies because we know that IDH mutations tend to be sensitive, but we don't always have that at go. And then I think I would agree with Dr. Desai, institution by institution, we often have different things that lean us one direction or another, but the IDH2 mutation doesn't tend to say to us, let's move to transplant in the first remission. I think we align there, Dr. Desai. I don't want to speak for you, but.
I'll move on to another question. Here is being asked, is there any indication that the stem cell transplant process actually creates new genetic mutations?
I would say in general, no to that. And it's a little bit of a tricky question because can you have, so part of stem cell transplant, you do get chemotherapy as part of what we call the conditioning regimen, where you get intensive chemotherapy followed by the transplant. And, can you, in theory, develop a secondary leukemia after a transplant? In theory, yes, but I think that in practical terms, it's not a big concern because one is that, and when we say stem cell transplant, I'm talking about allogenic stem cell transplants. You're getting someone else's, donor cells. Leukemia, survival from leukemia is not perfect, right? So our goal is to try to get that leukemia that occurred in the first place cured. So you get there, which is not always a guarantee post-transplant as well. Most of the relapses that happen post-transplant, if you look at it, are generally the original leukemia that has escaped, transplant, and then it would relapse. And if there is indeed a new leukemia, which is chromosomally completely different and mutationally completely different than the original leukemia, sometimes these tend to be what we call donor cell leukemias, where the donor cells, the leukemia happens in the donor cells themselves. So I would say that in overwhelmingly, allogeneic stem cell transplant doesn't create quote unquote new mutations. We're actually at the, we're still not at the point where we're curing everybody with leukemia to even sort of get there at 10 years that perhaps something different is happening. The sort of new leukemias could be just donor cell leukemia. So I wouldn't worry too much about whether the stem cell transplant is going to create more mutations or a new leukemia. The idea of a stem cell transplant is that your primary leukemia, the original leukemia, is too high risk and it's going to come back, and the stem cell transplant is likely to improve cure rate. So that I wouldn't worry about that aspect of stem cell transplant. The worry about stem cell transplant sometimes that you have to think about is, will you survive stem cell transplant? And that's where our BMT colleagues spend their careers trying to understand who will survive a stem cell transplant and not have transplant related complications. So I would say generally no.
Great.
Yeah, just I think we don't have a perfect handle on this. I think there's some interesting data that's come out of Hopkins from Lukáš Gondek, kind of talking and speaking to the fact that actually having CHIP in these stem cells actually improves BMT outcomes. I think it's early data sets. I think there's a lot of questions around this. There's also groups that are doing transplants that really believe that young stem cells are actually better than stem cells from older patients, with the idea that younger stem cells will have less CHIP mutations in them. So I'm not sure that we have a good handle on this. And I think for many of our patients, we have to worry about leukemia control and control of disease. And we know that transplant is the avenue to cure for many of our patients with intermediate and high risk leukemia. And we're trying to optimize that as best we can.
Yeah, I think the RUNX1 mutation was briefly touched on during one of the presentations, but Ted's asking if there are any new drugs or trials going on for this specific mutation.
I think the things that I've seen in the RUNX1 space have really been the use of BET protein antagonists and an interest in terms of the leukemogenesis that comes from RUNX mutations, kind of using or manipulating that pathway by using BET antagonists might be beneficial. I think there's a lot of research that's coming out of a multitude of institutions, including Penn, specific to RUNX1 mutations and others. And then I think there's a lot of interest with the menin inhibitors right now, although that may be less specific to RUNX1 mutations specifically, but more related to kind of the HOX-mediated kind of pathway. I'd be interested if Dr. Desai or Dr. Salman have other thoughts there.
Yeah, I mean, my only comment, there's a RUNX1, they're more focused on familial mutations. Actually I just had a meeting with them like a day ago, so that's why it's a little bit fresh, but they're focused on research looking at that again, particularly in the germline or familial situation, but also for patients that have acquired. It's a lot more challenging one, I think, to what Dr. Caraway is alluding to. I think we're trying to look at the pathways that are impacted when you have the mutation. A lot of patients, almost all with RUNX1, have other mutations associated with it. So we're probably not in the very near future, hey, we have this perfect drug for you, but we're trying to see if there are newer therapies that may have preferential activity or can be utilized in patients with RUNX1.
Great. A question here from David. I know we're a little bit over, so maybe we can close on this one. He's asking, how is FLT3 ITD positive with NPM1 positive considered intermediate prognosis? He was told his diagnosis of FLT3 is considered poor prognosis. So what's the difference or relationship between those two mutations?
So as we had, I think, had briefly mentioned, NPM1 is considered a good risk mutation. FLT3 ITD, depending on what we call allelic ratio or the relative percentage of FLT3 mutation, presence of mutations, can either push this up or down. So if NPM1 by itself would be good risk, FLT3 ITD, if it's in combination with it, will push it down to intermediate. If you have no NPM1 and FLT3 ITD high, then that's adverse. So FLT3 is ITD high is bad. NPM1 by itself is good. The combination together is generally intermediate.
Yeah, I think my comment, these are prognostic scores, right? So they have to look at all this data, and sometimes this is some of us sitting in a room and arguing with each other on what is good, middle, bad. I would say what's probably going to shape a lot of it going, I think we're all harping on the MRD is, right? There are already commercial tests, for example, InvivoScribe has an assay where you can look at, FLT3 down to 1 × 10⁻⁶. So I think with all these mutations, you're going to follow them, right? If it's still there, it's bad. Irrespective of likely, what that, burden was at baseline. And because we have some of these targeted therapies, that Dr. Caraway mentioned, and I mentioned a little bit, hopefully we can do things, either targeted or some novel cellular therapy or other option. But I think a lot's going to be really in regards to how you respond to therapy. I know there was one question in the chat, we don't know what the best time point is, probably after maybe 1 cycle of consolidation. If you're having high dose therapy with HMA venetoclax, probably after at least 2 cycles. Again, some of what's the best time point, we really don't know. I think checking more frequently than less frequently is helpful. But I think with what's good, middle, bad, it may really play out to actually how do you respond to your initial therapy, irrespective of what it is.
Yeah, I would just chime in. I agree. I think a lot of what was determined to land in either favorable, intermediate, or poor risk is really looking at cohorts of patients with these mutations and seeing how they did over time and reporting out on that. Now, all of those reports were done at a time where we were not using midostaurin in the upfront setting for patients with FLT3 mutations. And so, we don't know the impact of that and, the novel FLT3 inhibitors that we now have for patients as well. They're also, and it is not surprising if you were to go shop around from one institution to another and talk about, should I be transplanted for my NPM1 positive, FLT3 positive leukemia, you have to expect that you might get different answers there. And there's a lot of different pieces that go into that. Some of it is, as Dr. Salman and Dr. Desai are saying, it's how are you responding to therapy? Are you able to stay on therapy? How challenging is that? And when we have the dynamic checkpoints along the way, do we feel like we have good control of the disease? Because we can measure, is NPM1 gone? Is FLT3 gone? And so those are things that once we now have that sort of data, we don't necessarily know the trajectory of how patients do, because we haven't published on that and we haven't followed it as robustly as we want to be able to tell you, the exact patient with that scenario, the best next kind of path to go down. Hopefully
it's important. And it's important to also note that even when we say something is quote unquote good and we're monitoring, for example, NPM1, that can change with time. If you notice that the NPM1 testing is now coming up, then you're no longer good risk, and then you still might end up needing more therapy and transplant. So I think the trick is to choose the right therapy, do the best modalities of testing, monitor, assess the disease response, make further decisions based on how a patient is responding, and keep reassessing that decision with time, because things can change.
Yeah, all really good points. And I see Dr. Salman answering some questions via text that we haven't gotten to. So I'm sure everyone really appreciates that insight as well. We're going to wrap up today. A big note to myself is to have longer Q&A time next time, so we can make sure all questions are answered. But I'd like to extend a big thank you to everyone that was here today. Thank you to the audience for giving us your time and your wonderful questions. And thank you so much to our doctors for taking time out of your busy schedules to join us and share your expertise. We are so appreciative for everything you're doing. All the work you do is just so important. So we're so thrilled to have been able to do this today. As we close our very first event, I'd like to mention that if you'd like to go back and review the content that was discussed today, the videos will all be up on our website, healthtree.org/AML/community in the next few days. And we'll also send them out to everyone via email along with PDFs of the slides. So again, a big thank you to our sponsors, Bristol Myers Squibb, Amgen, AbbVie, Genentech, and Jazz Pharmaceuticals. Without your support, this program would not be possible. I hope each of you have a great evening, and we hope to see you again at future roundtables.